assessment of neonatal integumentary system. So what are our main objectives for this topic is, of course, for you to be able to name the three functions of the skin, describe the common skin lesions among the neonates, of course their appearance, be familiarized on that, and of course the appropriate treatment if there would be any. Then another thing is to familiarize yourselves with the use of the NSCS. So when we say NSCS, this stands for the neonatal skin care scoring. What are the criteria in doing this NSCS? So what are the functions of the skin? Of course, we have three functions of the skin. The first one is the physical protection, the heat regulation, and of course the sense perception. So for the mechanical, this one provides a protective barrier against the transepidermal water loss and of course the eternal invasions. And of course, it is a process of sloughing, prevents colonizations of the skin surface by bacteria and of course other organisms. And for the chemical or bacterial, the acidic surface, which is the pH, this defends against bacteria and of course microorganisms. And another thing is of course the production of melanin. This protects against damage from ultraviolet light radiation. And for the next function is of course for the heat regulation. This is the production and evaporation of sweat in our skin, and of course the dilatation and constriction of the blood vessels, and the insulation as well of the body by the subcutaneous fat. And with regards to the sense perception, of course that deals with the heat, the touch, the pain, and of course the pressure. So there are certain terms that we need to be familiarized, and the different terms are of course the atopy. So as nurses, we should know the family history of the newborn, and that includes of the history of any history of the eczema, asthma, or of course allergic rhinitis. And another term is the pH. This represents the acidity or the alkalinity of the solution on a logarithmic scale, where 7 is the neutral and less than 7 means more acidic, and greater than 7 means more alkaline. And another term that we will be encountering in dealing with this integumentary system is of course the presence of the vernix gaseosa, wherein this one stands for the waxy white substance in newborn skin. And of course, we'll be dealing of course with regards to the layers of the skin, which is the epidermis, the dermis, and of course the hypodermis, which is the subcutaneous tissue. And this one has been tackled before on your lecture. And of course we have the stratum corneum, which is the outermost layer of the epidermis, because we'll be as nurses in doing the assessment of the integumentary system of the newborn, we'll be checking the outer aspect of the skin. Okay, so we will be assessing that one by inspection. So what are the common newborn rashes? Of course, we have the erythema toxicum neonatarum. This one is most prominent on day 2. Although onset can be as late as 2 weeks of age, then often begins on the face and spreads to affect the trunk and of course the limbs. So palms and soles are not usually affected. Okay, so what are the clinical features? Erythema toxicum is evident as various combination of erythematous macules, the flat red patches. So the papules, which is the small bumps, and the pustules, and the eruption typically last for several days. However, it is unusual for an individual lesion to persist for more than a day. So what would be the treatment? So there is no treatment actually for this kind of skin disease. So this one is the visual presentation of that kind of newborn rash, which is the erythema toxicum neonatarum. Okay, if you will be seeing that kind of presentation from the newborn, and there's no itchiness or like that, or even fever, it's normal. So it will also be removed from the eventually from the newborn skin. Okay, another kind of newborn rashes or the skin disease is of course the neonatal milia. So this affects 40 to 50% of newborn babies. So initially only a few lesions first, then it will lead to, or it will be in it will be numerous after a while, or after a few days. Then the clinical features, of course, it is harmless cysts present as tiny pearly white bumps just under the surface of the skin, so often seen on the nose, but may also arise in the mouth, okay, or in the mucosa. So this one is what we call the Epstein pearl, okay, if it's in the mucosa, or in the palate, which we term as bone nodules, or more widely on scalp, face, and of course the upper trunk. So same, these lesions will also heal spontaneously within a few weeks of birth. But then, if you will be noticing some of these rashes that that is being already spread on the scalp, always check the site, okay? Because most of the time, if there will be more rashes on the scalp, sometimes even though it's normal, if it's not being prevented from wet, it will also create some problems, okay? So might as well check for the scalp of the newborn, okay? If there is no redness, no scaly something like that, and make sure that it's totally dry, okay? So that it will not lead into a very severe kind of skin diseases. So how is it look like, the neonatal milia? So this one is the visual presentation of the neonatal milia. So as you can see from the nose of the newborn, so that's it. So you will be seeing that kind of course of skin diseases on some other parts of the newborn. So if you will be seeing like that, that's normal, and it will resolve also spontaneously. Then another thing is the miliaria, or the heat rash, from the term heat rash. So this arises from the occlusion of the sweat ducts. So in neonates, lesions commonly appear on the neck, the groins, the armpits, but also on the face. So as you can see again, if this one will be appearing on the groins, armpits, okay, you need to check it every now and then. Make sure that that area is dry. Okay, the clinical features, 1 to 3 millimeter papules, or either vesicular or papular. The treatment, of course, if it's from the term heat rash, so you need to remove from the heated, humid environment, or adjust the incubator temperature if the newborn is being placed in the incubator. And if you will be seeing this kind of rashes from the newborn, do some documentation and refer that immediately to the pediatrician. And what another thing is cool bathing, or apply cold compresses on that affected part. And topical steroids may also be used to facilitate relief while the condition resolves. Another kind of a skin rash also is the pityrosophorm folliculitis. This one is what we call the neonatal acne or milk spots. This affects babies within the first few weeks of life, and increased due to the increased activity of the neonates' sebaceous glands, which cause inflammation and of course folliculitis. So what is the clinical features of this? So this one is a erythematous dome-shaped papules and superficial pustules, which arises in crops, okay? Crops or clustered, commonly affecting the cheeks, the nose, and of course the forehead. This rash is not itchy, okay? So treatment will resolve within weeks without treatment, or may be treated with the ketoconazole shampoo, okay? So diluted one, it may be diluted into 1:5 with water, and apply with a cotton bud also twice a day. So, and can be also rinsed off with water after 10 minutes. Or you may also apply hydrosol cream twice a day to the affected areas until the rash has resolved. Actually, with regards to ointment that we will be using with the newborn or the neonates, that one should be prescribed by the pediatrician. Okay? Oh, so this one is the visual presentation of that kind of skin diseases. Okay, what again is that one? The pityrosophorm folliculitis. So as you can see from the face of the neonate, it has been formed into a clustered one. Okay, so on the left side is of course it appears on his forehead, and the other one is on the cheek. Another kind of skin disease for the newborn is the infectious lesions, and one kind is, of course, the Candida diaper dermatitis. So from the term itself, meaning the lesions or the rashes has been acquired in using the diaper. Okay, this one is a fungal infection of skin in the diaper area, of course, very much specific with the buttocks, the groin, the thighs, and of course the abdomen. So you may as well check also for the rash as well. And it is also caused by organism C. albicans and shows as moist erythematous eruption, often with white or yellow satellite pustules. So what would be the treatment? Of course, we'll be using the antifungal cream or that ointment preparation, or might as well the nystatin. So most of the time that we're using this kind of cream, which is the nystatin. So this one is the visual presentation of the diaper dermatitis. So as nurses, it is our responsibility that if the newborn is, if you will be assigned, in the NICU department, it is your job to avoid this kind of diaper dermatitis, because as the one assigned in that specific area, having this kind of skin diseases of a newborn is a negligent on your part. Okay, so might as well, if you will be assigned in the NICU, change the diaper as often as possible and avoid having this kind of dermatitis. If there is a certain skin diseases or a small kind of skin rash, might as well refer that one to the attending physician, and as a nurse, always maintain that area dry, okay, to prevent harboring microorganisms. And another thing is always do a checking of the diaper every now and then to avoid to prevent these kinds of skin rashes. Okay, and if you will be assigned as well in the pediatric unit and you will be receiving admitting a newborn patient or a pediatric patient who have fever, might as well check not only for the lab results of urinalysis of the newborn, but might as well check for the diaper of the patient, because most of the time the fever that the newborn is having is being acquired not only from the urinalysis, from the UTI, but also from the diaper of the patient. If that one is left, if the diaper is being left there in the perineal area of the newborn, and it will lead to these kinds of dermatitis, it will also cause fever, okay, and irritability to the newborn. So what would be the management with regards to the nappy care? The perineal environment is prone to changes in the skin barrier, causing skin irritation. So increased moisture, prolonged contact with irritants, and an alkaline skin surface may contribute to the skin breakdown. So nappy changes should occur at regular intervals, were clinically appropriate to avoid irritation to the perineal area. And evaluation of the perineal area is required at each nappy change to ensure early identification of the perineal dermatitis and candida infections. So as nurses, if you will be changing the diaper of the newborn, make sure to check, assess for the perineal area. Is there any rashes that is being seen on the side? If none, make sure that you maintain the dryness of that specific area prior in giving another set of new diaper. Then what else? Disposable nappies are preferred. Then cotton balls or soft disposable towels or the ready wipes with warm water are the preferred cleansing method. Okay, if you will be having a newborn patient with this kind of dermatitis, it is best to clean the specific area with warm water using the cotton balls. Then squeeze that one on this affected part, then after that dry it, then change it with a new diaper. Then a pH neutral cleanser may be used if stools are dry and difficult to remove. Then wipes should be avoided actually, but then if you will be using, if in case that the mother gave you the wipes, make sure to check if it's free from alcohol and fragrance, because that's the safest wipe that you can use for the newborn, specifically if the newborn have this kind of dermatitis, because it's a very it's not advisable to use a certain product with a strong alcohol and of course fragrance with that kind of skin diseases. And barrier creams should be used on all neonates at risk of perennial dermatitis at every nappy change, at the first signs of erythema or skin breakdown. And the removal or barrier creams between nappy changes is not necessary. Rather, apply another layer. Okay? Do not remove the cream. Just apply another layer. Unless it is being soaked by the stool or urine, that's the time that you will clean that one. Okay? And after cleaning that one, again, apply a cream so that it will dry the lesions. And barrier creams containing plant extracts and or fragrance should be avoided. So, risk factors of perennial dermatitis include frequent stooling, antibiotic use, malabsorptions, opiate withdrawal, and of course, abnormal rectal sphincter tone. Another kind of lesion is the lesions from trauma, wherein the common trauma that we've seen from the newborn or that we've encountered in the newborn is the intravenous extravasations. So this is the vascular access sites in infants should be assessed hourly. Okay? Then evaluate for patency and extravasations. If apparent or if patency is not certain, you need to remove the IV line immediately. Then if extravasation occurs, elevate the extremity and avoid heat or moist dressings. Then topical antimicrobial ointments may aid in this kind of intravenous extravasation. So how is it look like? So this one is what we call the IV line extravasations. So as nurses, when you inserted an IV line to a newborn, make use of the clear tape. Okay? One example of that one is, of course, I'm not promoting any product, but based on my experience, we're using the Askina, okay, the clear tape, so that you can easily see the IV site. If you will be using the colored tape, even actually this kind of tape, the micropore, actually it's not anymore advisable in using that one on the IV site of the patient, specifically of course with the newborn. If you will be using the clear tape, you will be anchoring on the IV site, then on these arms as well with the support the splint. Of course, you can easily visualize the IV site if you will be using the clear tape. Okay? Then avoid also using the diaper in covering the site, because some of the nurses, the purpose of doing that, why they were covering the diaper, the IV site of the newborn, para raw hindi magalaw ng newborn, para raw hindi mahatak, kaya nila nilalagyan ng diaper. But it's a no-no actually. If your reason is that, the reason why you're putting diaper on this one, might as well, why not cover the cover the other hand with the diaper and not the side, so that if in case that the newborn might touch the IV site, she cannot be able to grab the site with his fingertips because it's already covered with the diaper. So might as well use the clear tape on the side, then support it with the splint, then use the clear tape on placing the clear tapes on this side, of course with the support of the splint, and on this side as well. And the diaper should only be used on the other arm if you're afraid that this hand might touch the IV site. Okay? But never use the diaper on the IV site. And another thing is, if you will be giving an antibiotics to the IV line of the patient, specifically of the actually in the newborn, make sure if you will be giving antibiotic, make it or give it slowly and do the sash method technique. When we say sash method technique, you need to flush the IV site. After flushing it with a saline, with only a few amounts of saline, like for example a 0.5 cc of saline, push it with 0.5 cc, then inject the antibiotic slowly, and after injecting the antibiotic slowly, flush it again with the saline solution, so that it will not be painful on the part of the newborn. Then same thing, it will not easily dislodge. The IV line will not easily dislodge because you did not push thoroughly the antibiotic to the IV site of the newborn. Okay, so that is what we call the extravasation, IV extravasation. Again, please be mindful of that, because any kind of incident like this, the extravasation, it only means that there is a negligence on the part of the nurses. Okay, so please avoid this kind of IV extravasations. And moving on with the NSCS criteria, which is the neonatal skin care scoring. So we have 3 categories in the NSCS criteria. We have the dryness, erythema, and of course the breakdown. Of course, when we score them 1, it only means that the patient has a normal and no signs of dry skin. Same with erythema, no evidence of erythema, and non-evident of breakdown if it's 1. And if it's 2, of course, there is a dry skin with visible scaling. Then, for erythema, again, there is a visible erythema, less than 50% of the body surface area, and a small and or localized area of breakdown. And for the 3, of course, there is a very dry skin. Not only dry skin, but there is also not only scaling, but there's already a cracking and or fissures present. And for the erythema, if in 2 we have less than 50, this time we have greater than 50% of body surface area have this kind of erythema, and the breakdown is very much extensive when we score it to breakdown as 3. Okay, so that is the way how to do the neonatal skin care scoring. So for the interpretation, if a neonate scores a single score of 3 in one area, like for example in dryness, she scored 3, so that one is already a red flag. Okay, or if it's there is a combined score of 6 in any categories, and the dryness, erythema, and the breakdown and above, so that one is already a red flag and needs to be referred to the dermatologist. Okay, so that's it for today. So thank you very much for your time, and please be ready on your final exams by next week, and hope to hear from some of you who have problems with regards to their grades, but most of the time they're absent for today. So I'm just hoping that there will be no expectations from them, because I've been reminding you many times of that one. Okay, so thank you very much, and hope to see you by next week. Thank you.